Hey, thanks for making it to Veterans Info Tap. I'm glad you made it. Let's talk about Project 2025. What's going on with it? What are the suggestions for the VA and veterans specifically? And look, it's a suggestion. I personally don't think any elected official out there is going to throw their neck on the chopping block and do something so egregious to where they won't get reelected or have somebody succeed them that they want to be in office. So there is that. Now, just like the congressional budget office, there's recommendations out there. The congressional budget office, for example, isn't worried about somebody getting reelected. They're worried about the budget. And so they're giving suggestions on how to manage that budget. The congressional budget office, for example, threw out if veterans make over a certain amount per year, they shouldn't really get their VA benefits as one way to save money. So let's take things with a grain and understand what is actually being recommended. And there could be good recommendations. And if there are, you should be reaching out to your congressional member and saying, hey, this is a good idea and I support that. And if there's horrible ideas, then you need to say, I don't support that. Loud mouths are the ones that actually get fed, right? So we need to voice our concerns and our ability to support certain things. Either way, whether it's a concern or support, we need to voice it. So with that, hit the thumbs up, subscribe, share with a friend, all that good stuff. I really appreciate it. Hit the thumbs up for me. It really means a lot. And if you want to support the channel in other ways, consider being a member. You can go to the homepage. You'll see the highlighted members and a join button. So what I'm going to do here is I'm going to go through the almost 1,000 page document. Obviously, nobody wants to hear me try to stumble through that. But there's a couple sections in the VA Health Administration and the Veterans Benefits Administration sections of this document that I'm just going to read through for situational awareness, if you will. And again, if you're worried about any of this stuff and it's giving you stress, file an intent to file if it has to do with claim stuff and reach out to your congressional member. If it's not stressing you out and you're actually pro some of these things, then voice that too. Look, the worst thing that any of us can do, honestly, is just go, I'm not for anything about anything within that, even if there's something good for us, or vice versa, right? I'm for everything in that just because I'm going to be for everything in that. That sounds ridiculous. We need to understand it, and we need to voice our support or our concern either way with our elected officials, right? So anyway, let's jump into it. Veterans Health Administration, and there's several bullet points here, and it says needed reforms. Rescind all departmental clinical policy directives that are contrary to principles of conservative governance, starting with abortion services and gender reassignment surgery. Neither aligns with the service-connected conditions that would warrant VA's providing of this type of clinical care. And both follow the left's trend of abusing the role of government to further its own agenda. You agree or you don't agree? Next bullet. Focus on the effects of shifting veteran demographics, at least during the next decade. The VA will experience a significant generational shift in its overall patient population. Of approximately 18 million veterans alive today, roughly 9.1 million are enrolled for VA healthcare, and 6.4 million of these enrollees use VA healthcare consistently. These 6.4 million veterans are split almost evenly between those who are over 65 and those who are under 65. But the share of VA's healthcare dollars is spent predominantly in the over 65 cohort. That share increases significantly as veterans live longer and use the VA system at a higher rate. VA enrollments of new users are increasingly at risk of being exceeded by the deaths of current enrollees, primarily because the significant numbers of Vietnam generation are reaching their life expectancy. So in other words, we are a shrinking population, the veteran population, and it's even a smaller population that get connected with the VA for healthcare. And essentially what this is saying is for every X number of new veterans into the healthcare arena, more actually die and fall out of it. So we're not filling the bucket fast enough. That bucket that has holes is slowly draining, and we keep adding to it, but we're not adding fast enough, if you will. All right, so moving on, reaching their life. The generational transition from Vietnam-era veterans to post-9/11 veterans will take several years to complete. The ongoing demographic transition is a catalyst for needed assessments of how the VA can improve the delivery of care to a number declining and a differently dispersed national population of veterans and population of veterans. A population that is more active, reaching middle age or retirement age, and migrating for a lifestyle and career reasons. So we have a moving population as well. At the center of the VHA, the Veterans Healthcare Administration's evolution during the generational transition, is an ongoing tension. Some of it politically divided between direct care for veterans provided from inside the VHA system and community care for veterans who are referred to private doctors participating in the VHA's two community care networks. In recent years, the budget for community care has grown as demand from veterans has risen sharply, sometimes outpacing the budgets for community care at individual medical centers. The Trump administration made community care part of its veteran-centric approach to ensure that veterans would be able to participate more fully in their health care decisions and have options if or when the VHA was unable to meet the needs. True. So back during the Mission Act kind of period, there was the Mission Act, the Blue Water Navy, and then there was another one regarding what was it? I want to say it was AMA, and I'm trying to remember what that stands for. Or it was the Appeals Modernization Act. There you go, the AMA. So those things all kind of happened around the same time, and in all of that stuff, and I believe it was the Mission Act, was when they really implemented this community care thing where they expanded it a little bit and made it a little more bolstered up, allowing for the community care. So moving on, it says here, the Biden administration has watered down that effort, has sought various procedural ways to slow down the rate of referrals to private doctors, and at some facilities is reportedly manipulating the community care access standards required by the VA Mission Act of 2018. If the makeup of Congress is favorable in 2025, which it appears to be so for this purpose, the next administration should rapidly and explicitly codify the VA Mission Act access standards in legislation to prevent the VA from avoiding or watering down the requirements in the future. In other words, keep the ability for folks to receive the care at the community care lane as it was drawn up. So first and foremost, a Veterans Bill of Rights is needed so that veterans and VA staff know exactly what benefits veterans are entitled to receive, with a clear process for the adjudication of disputes, and so that staff ensure that all veterans are informed of their eligibility for community care. Currently, veterans are not routinely and consistently told that they are eligible for community care unless they request information or are given a referral. True. To strengthen community care, the next administration should create new secretarial directives to implement the VA Mission Act properly. Sections for consideration and areas for reform include the following. And then they have a bunch of things regarding family caregiver program, and the community care aspects. And then, so we'll skip that stuff, go to the next couple bullet points here. Require the VHA to publicly, on all aspects of its operation, including quality, safety, patient experience, timeliness, and cost effectiveness, using standards similar to those in Medicare accountability care organization programs, so that the government may monitor and achieve continuous improvement in the VA system more effectively. So the VA wasn't within budget. We risked benefit payouts here in 2024 due to a budget miss by over $10 million, closer to $15 billion, and Congress had to step in. There a little more oversight is obviously needed. Encourage VA medical centers to seek out relevant academic and private sector input in their communities to improve the overall patient experience. All right. Next talks about budget. So that was the section that was labeled needs reforms under VHA. Okay, needs reforms under VHA. Then there is budget. There's a small little section on budget in VHA. I'll go ahead and just read that little piece here. So, conduct an independent audit of VA similar to the 2018 Department of Defense audit to identify IT, management, financial, contracting, and other deficiencies. Assess the misalignment the misalignment of VHA facilities and rising infrastructure costs. The VHA operates 172 inpatient medical facilities nationally that are in average of 60 years old. Some of these facilities are underutilized and inadequately staffed. Facilities in certain urban and rural areas are seeing significant declines in the veteran population and strong competition for fresh medical staff. In 2018, Congress authorized an asset infrastructure review, an AIR, I do remember that, of national VHA medical markets to provide insights into where the VA healthcare budget should be responsibly allocated to serve veterans most effectively. However, the Senate Veterans Affairs Committee lacked the political will to act on the White House's nominations of commission members, and this ultimately led to the termination of the AIR process. The next administration should seek out agile, creative, and politically acceptable operational solutions to this aging infrastructure status quo. So some of you may be in areas where your VA facilities are relics, and so this is kind of addressing that. Reimagine the healthcare footprint in some localities and spur a realignment of capacity through budgetary allocation specifically. And it says two different things here. Embrace the expansion of community-based outpatient clinics, so CBOCs. Embrace the expansion of community-based outpatient clinics as an avenue to maintain a VA footprint in challenging medical markets without investing further in obsolete and unfavorable VA healthcare campuses. Explore the potential to pilot facility sharing partnerships between the VA and strained local healthcare systems to reduce costs by leveraging limited talent and resources. Seems smart. If you didn't quite catch that, it says explore the potential to pilot facility sharing partnerships between the VA and strained local healthcare systems. It's a win-win because you're now sharing this facility. It's helping out your local environment and the VA as well. So let's move on. The next section is personnel, and I'm just going to skip that. And we're going to get into Veterans Benefits Administration. Veterans Benefits Administration needed reforms. So we'll do needed reforms, and then we'll do budget, and then we'll end it. So this is, again, what the Project 2025 is actually saying with regard to the VA, specifically to VBA now. And I'm going to throw this out there. I'm going to put this in the link. If you feel as though you need a nexus letter, DBQ, anything like that, in order to tighten up your evidence for your VA claim, I'll put a link to the Veterans Info Tap Med team that can help you with a free consultation, and you can decide what you need. Remember, there's two separate things here that I'm talking about. Nexus letter does what? Helps you get service connected. A DBQ does what? Helps you get the appropriate rating. So if you have both, right, you're going to set yourself up for success, hopefully, with getting service connected at the appropriate rating. Nexus letter, DBQ. So I'll put the link in the description and in the comments for you, and let's move on. So, Veterans Benefits Administration needed reforms. The most evident and ongoing concern is the complexity of benefits, which can lead to confusion for the veteran, and if not mitigated early in the veteran's interactions, long-term distrust of and animosity toward the VA. Okay, I agree. I think everybody agrees with that. Wholesale benefits reform. Wholesale benefits reform is unnecessary and politically a third rail, but effective managerial approaches and technology tools that currently exist in the private sector could be employed to improve existing VBA activities. Yes, I agree. The problem is most pronounced in the disability claims process. Everybody that watches this would agree, which needs more and better management attention focused on streamlining the procedures involved in processing claims and administering benefits. The VA must improve timeliness of claim adjudication and benefits delivery. Everybody would want their claim to happen faster. Makes sense. So far, there's nothing to disagree with. Let's move on. Veterans want the VBA, Veterans Benefits Administration, to provide timely responses to their requests for benefit support, render empathetic customer service, and understandable, keyword, understandable explanations of those benefits, and deliver those benefits without frustrating delays, weeks, not months. All right, there's several bullet points here. Looks like 5 of them. And again, this is under the needed reforms. Identify performance targets for benefits. Report publicly on actual performance each quarter and use these metrics to drive consistent improvement. So basically setting up kind of like KPIs, right? Key performance indicators, something that they can hold people accountable to deliver the services. All right, so next one. Develop a new pilot, Express 30, commitment for veterans, first fully developed disability compensation claim, and organize the VBA to complete the first claim in 30 days. That would be insane. So develop a new pilot, Express 30, commitment for veterans, first fully developed disability compensation claim, and organize the VBA to complete the first claim in 30 days. That is jamming. Could you imagine getting your claim completed in 30 days? And oh, by the way, there was some claim clinics out there where veterans were able to go in. They had the whole team there, and they were being able to knock out a claim in a day. So 30 days is not out of reach, right? Next one. Hire more private companies to perform disability medical examinations. Delays in completing the examinations could be eliminated with more external capacity. So already the VA has contracted out the majority, or all in some cases, of their C&P exams, their disability medical examinations. So all they're saying here is hire more, bring more on, so that way these C&P exams can happen even faster. That's what I'm reading anyway. Next one. There's 2 more bullets. Here's the next one. Increase automation. Hiring additional staff to process claims is costly, is inflexible, and has yielding mixed results. Attempting to change laws and regulations simply to adjudicate claims would be a Herculean effort. Herculean effort, given their complexity. The best way to provide benefits faster and more accurately is by using technology to perform most of the work. Technology currently exists in the private sector, but the VBA lacks the experience to use it. This would be more of an organizational challenge than a technology hurdle. Agreed. Technology exists. It's a matter of bringing people up to speed with utilizing it. Last bullet point on the needed reforms: reduce improper payment and fraud. Okay, yes, please reduce improper payment and fraud. About $500 million is improperly paid out each year. Better tools, training, and management could reduce this substantially, but rule changes at the departmental level would be needed. Okay, now that was all. That was it for the needed reforms. Now we're going to jump into budget. Under the budget section, and it's short here, and then we'll wrap it up. Under the budget section, it says budget. The VA schedule for rating disabilities has assigned disability ratings to a growing number of health conditions over time. Some are tenuously related or wholly unrelated to military service. The further growth in presumptive service-connected medical conditions pursued by Congress and veteran service organizations, begun with Agent Orange and most recently for burn pits and airborne toxins, has led to historic increases in mandatory VBA spending in recent years. The VA has a time-phased plan to has a time-phased plan to reassess the rating schedules, which, let's pause right here and talk about what's being said. So, yes, there is an assigned rating schedules that are either wholly related or unrelated to military service, right? So the Humvee rolled over and shattered my leg, and now my leg's all messed up. Completely service related. I joined the military. I never had headaches before, and now all of a sudden I have migraines, and I just was an HR worker the whole time I was in. But I'm service connected for my migraines. The military didn't really cause that, but because the way the laws are, we're able to get service connected for that, in my opinion, because we signed the blank check and we came in as a clean slate, and now here we are. Now, you can attribute it maybe to all the different shots we got, right? Who knows? But so yes and yes. Yes, there's conditions that are 100% connected due to military service, and then there's some that are really not because of your time in the military. Sure, agreed. Yes, Congress has enacted more presumptive conditions for starting with Vietnam and moving through to burn pits, most recently the PACT Act, and that has increased the spending huge, right? Sure, I get it. And yes, the VA has a time-phased plan to reassess the rating schedules. Most currently, the last one that we're working with here is the proposal to change the rating schedules for auditory, respiratory, and mental health. Those three rating schedules are proposed changes in process with a final date of April 2025. And they've been in process for the last almost 3 years now. So this is not new information. This is all just spelling out where we currently are. Now let's move on in this and see what it says. But this internal process can be slow and laborious or labor intensive. It requires Office of Management and Budget, the OMB, approvals and can become politically charged both in Congress and with veteran service organizations. Okay, so all they've done is just say what currently happens. Again, this is under the budget section. There's 3 bullet points under the budget section, and that's what we're going to read now. 3 bullet points. And again, this is in the Project 2025 900 and something page document under Veterans Affairs. First bullet, The next administration should explore how the rating schedules reviews could be accelerated with clearance from OMB, which is the Office of Management and Budget, which is under the President's office, I believe, to target significant cost savings from revising disability ratings Let's start that one again just to make sure we understand exactly what it's saying. The next administration should explore how rating schedule reviews could be accelerated with clearance from OMB to target significant cost savings from revising disability rating awards for future claimants while preserving them fully or partially for existing claimants. So this right here is one of the biggest concerns that people talk about. And here's the two things. Out of this, there are two things. One, expediting it. So instead of taking 3 or 5 years to implement a rating schedule change, they would like to expedite it. Okay? In some cases, that might not be a bad thing. In my opinion, there are times in which the rating schedule changes become more favorable. There's other cases where they become less favorable, right, for veterans. So it just depends on which way it's swinging, whether or not you like the fact that it gets expedited. Now, having something expedited, it doesn't really change the end result as far as the big picture is concerned. The more concerning part is the preserving the rating status for existing claimants, which I'm assuming would be currently service-connected veterans, should be 100% grandfathered in, and they should be preserved and held to the current rating schedule. And there is a bunch of law, public law, the Code of Federal Regulations, it has it in the M21, public law, all this stuff, all over, talking about how when the Secretary of the VA changes a rating schedule, the change to that rating schedule alone would never warrant the reduction for a already service-connected veteran in that same rating schedule. So the concern here is one word, or actually two. So it's while preserving them fully or partially for existing claimants. So the or partially part would be a no-go, right? Partially should be a no-go. They should be fully, right, for existing claimants. Now, the other way you could look at it is, okay, well, maybe you can't say fully because the person is going to be reduced at some point, right? So, in other words, if you had cancer that was active and then the rating schedule changes for that specific rating schedule where cancer's listed, and then you go into remission, well, you're not going to be fully preserved because you went into remission. So now they're going to lower your rating because now you're in remission. You've beat the cancer. Now they're going to look at residuals. So that would then be a partial for existing claimants. So you could read that either way, and so it would be nice to get a little more, I guess, clarity on what exactly they're saying. I guess it's hard to squeeze it into almost 1,000 pages. Joking, because it's obviously there's a lot of information. So the next one here, VBA's information technology top-line budget should be re-examined and reassessed in light of the need for expanded automation across the enterprise. Traditionally, VHA captures the largest majority of VA IT funding. The VBA needs to make a case for a larger IT budget with clear requirements to support that request. And I agree. That is true. Then it moves into human resources stuff on the VA and their budget and personnel and so forth. So that's it under the VBA and the VHA. And again, the only thing that was a super red flag would be that one word of partially, right? That one word under budget of partially for existing claimants. But you can't, unless it's a static condition where, you could get reduced even after a rating schedule change because your condition got better, right? Maybe you had a mental health condition, or maybe you had some sort of a hiatal hernia or something, and your condition, got a little bit better. You could get reduced. So even if the rating schedule changes, if your condition gets better, you could be reduced and only maintain a partial portion of your rating. So I think it kind of just matters how you read into that. So with that, thanks for watching. I appreciate you. Have a great one. And remember, if we don't take care of each other, something went wrong.